Good afternoon. Welcome to the COVID-19 webinar series. My name is Tim Murgo. I'm the current chair of Education Committee for CHEST, and I'm here on behalf of the COVID-19 task force. I want to start by saying a few words about this group. It's a very diverse group of faculty at CHEST that was created by Stephanie Levine and Stephen Simpson, the presidents of CHEST, about 15 months ago. It was an initiative as our organizational response to the pandemic with the intent to curate knowledge and bring some order in that chaos of information or misinformation that we were dealing with in March and April of 2020. With the amazing staff support, this group has created a monumental amount of work. And we invite you to check our website, the resource page, where you will find very easy to use infographics, a summary of the literature on different subject matters, and recordings of the webinars like the one today. It is my pleasure to introduce the panel today. We will be discussing complications from cancer, including pleural effusion, airway obstruction, and immune-related pneumonitis. We have Dr. Mary Jo Fiedler, who is an associate professor of medicine at Rush University in Chicago, where she's also section chief of medical oncology. Dr. Fiedler is an accomplished researcher in immunotherapy and TKIs for lung cancer and head and neck cancers. We have Dr. David Feller-Cobman, a professor of medicine and interventional pulmonologist, who's a section chief at Dartmouth-Hitchcock University. And Dr. Feller-Cobman is also an author of many guidelines and statements pertinent to management of malignant pleural effusion. And we have Professor Eric Adell of Mayo Clinic, Rochester, master educator and clinician, an author of many papers on airway obstruction, and on a personal note, a friend and a mentor. So the learning objectives, there are a few for each particular topic, but overall, we will address these topics: pneumonitis, malignant effusion, and malignant obstruction. And we'll talk about diagnosis and management and how COVID-19 pandemic impacted our practices in regards to these three disorders. So I want to set the stage by highlighting a few papers that have been published in the last few months in regards to COVID-19 and malignancies. So we have learned that the mortality of patients with cancer and COVID is much worse than either COVID alone or cancer alone. And that's especially relevant to thoracic oncology. That was a paper published by one of my current colleagues on medical oncologist while she was still working in Italy, Dr. Graziano. Now, because of the delayed appointments, decrease in screening, and we were seeing now a decrease in the number of new lung cancer diagnoses. There was one paper that showed that if you look at the month of March and June 2020, compared with 2019, the number of new diagnoses of lung cancer has decreased by approximately 30%. A few papers from UK and Australia predict that we will be dealing with a higher mortality and huge economic costs, likely because of stage shift that we will be seeing for lung cancer. There was a question from one of the participants. As you know, you had the ability to submit questions when you registered for this webinar, and we have a few of them. But I will start with one that I think it will start the conversation. And that was, did the pandemic have any effect on your procedural volume for managing malignancy, or on overall the number of patients with lung cancer that you encountered in your practice? So how about we start with Dr. Mary Jo Fiedler. What was the impact of the pandemic on your thoracic oncology practice in regards to volume?
At my institution at Rush, there was certainly a temporary hold on elective procedures, which lasted for quite some time. In general, they tried to push through, lung cancer surgeries and some of the other surgeries that were thought to really have an impact on patients' mortality. We did have a little bit of a dip in volume. If you look at the total numbers, they weren't off by too much. And if you look at the oncology our infusions were down by about 10% with the COVID. Visits shifted to over 60% virtual. And we had patients who were getting their labs drawn, having a virtual visit, and then just coming in for infusions if they needed it. And for patients on maintenance type therapies, for example, especially the immune checkpoint inhibitors, if they had been on their treatment for more than 2 years, we were really pushing to discontinue because the pros seemed to be outweighed by the cons. And at that time, we didn't have any real safety information about immune checkpoint inhibitors and COVID. Since then, the same authors you mentioned of the Teravolt study did put out a subset analysis showing that immunotherapy doesn't appear to have a huge impact on COVID-related mortality, but certainly keeping people out of the medical center seemed to make sense. And we also had to close our satellite infusion clinics. We have 2 satellites in the western suburbs, and the hospital needed the IV poles, so we pared down. So those are the main changes that we had.
Well, thank you for sharing that, Dr. Feller-Kopman.
So I don't want to use the word lucky for our procedural volume, but unlike a lot of the other surgical subspecialties where they took a really, really big hit, and we're actually not doing any surgeries and redeployed to some of the COVID ICUs in our institution. We really tried to push that lung cancer and pleural disease were tier 1 procedures. These are patients that really needed to have their continued evaluation. So though our numbers didn't drop so much, the process and the impact on the whole team was really quite significant. Everything from registration to patient preparation to getting them in the room to room turnover time, making sure that you're in a negative pressure room to recovery, to even having a loved one in recovery as the patient's waking up from anesthesia. It really impacted that whole process more than the numbers.
Dr. Dell?
Yeah, it did have an impact on the overall number of procedures that we were doing. We tried, as Dr. Feller-Kopman just articulated, that we tried to prioritize based upon the medical need as seen at the urgency of the disease process. But we could not handle the volume because of the process changes. We went probably 50% capacity for several months in order to just meet the demands of the infectious disease requirements to try and reduce the transmission. It was particularly difficult in the beginning where we weren't quite sure of the transmission. If you remember, we were fearful that this was more than just aerosolized transmission, so it impacted a lot. Once that became evident and we got into the groove, I think we were able to maintain and get back to our volumes fairly quickly. But there's no question that we had to prioritize some patients lower than we would have done in the past. The comment about stage shifting is going to be an interesting one. It's probably the combination of a combined slowdown rather than individual practice slowdowns, because the people themselves, I think, were reluctant to go out, where in the past we may have seen them. So a combination of the capacity being decreased, but also people's desire not to get out and be potentially exposed. That's it's a direct impact of the pandemic, but it's an indirect impact of the facility or the capacity changes, I think.
Well, thank you for sharing your institutional experience. Now let's move into the subtopics for today. So Dr. Mary Jo Fiedler will lead the conversation on immune-related pneumonitis diagnosis and management, and how COVID can mimic this entity. I will stop sharing the screen for Dr. Fiedler to take over.
Thank you for having me participate in this panel. It's nice to see treatment perspectives outside of my oncology bubble and thoracic surgery bubble. So the learning objectives for this part of the program are to list the diagnostic criteria for immune-related pneumonitis, identify and describe management strategies for immune-related pneumonitis based on severity, review guidelines and consensus statements for any changes that may pertain to the COVID-19 pandemic, and also highlight how the COVID-19 has impacted diagnosis and management of immune-related pneumonitis. I have a case study. This is an 83-year-old woman who was diagnosed in December of 2020 with stage 3 T2N0 squamous cell carcinoma of the left lower lobe. She underwent definitive chemotherapy and radiation with carboplatin and paclitaxel that finished March 4th, 2021. She began consolidation durvalumab April 13th, 2021. And shortly after her first dose, she was admitted for exacerbation of sciatica, which sort of had been building since being deconditioned from chemoradiation. But promptly she developed, after admission, fevers to 102 degrees, and she had a CT scan. Her oxygenation requirements did not dip considerably. The scan was mostly done because of the fever. I'm not clever enough to know how to do a scroll, but I tried to capture an image that showed the bilateral infiltrates. Again, her tumor was in the left lower lobe, but clearly these infiltrates are outside of that particular lobe. So we have the differential diagnosis, and I was going to see what our panel members thought about the differential diagnosis and next steps that they would take. So the ones I thought of, the first one being an acute infectious, sorry for the typo, infectious process, radiation pneumonitis, immune checkpoint inhibitor pneumonitis. Dr. Feller-Kottman, you want to comment?
Sure. So I think it's really difficult, especially in this past year, to differentiate checkpoint inhibitor pneumonitis and acute infection. The radiographic presentations of both of those, especially with COVID, are extremely variable and can significantly overlap. I think if you go back to the CT images, I personally would put radiation pneumonitis slightly lower on the list because it doesn't have the typical line that disobeys anatomic boundaries, and you're also getting some contralateral ground glass inflammation in the right upper lobe there. Now, that's not to say that can never happen, but it would be lower on my list. So then the question is, do you need a diagnosis to guide therapy? And if you do, how are you going to get that? Bronchoscopy is clearly a way that you could evaluate for infection. You have to weigh the risks of the procedure, both, and this is one of the key things over this past year, is previously we always really weighed the risks of the procedure to the patient. But now all of a sudden, especially early in the pandemic, we were really concerned about the risk to staff and our trainees. So at Hopkins, for example, I just at Dartmouth about 5 weeks now, but at Hopkins, we basically made aerosol generating procedures attending level procedure. There was a pulmonologist, a nurse, and an anesthesiologist in the room. There weren't trainees, there weren't students, there weren't any extraneous, I don't want to say extraneous, but additional people who would normally be there to help for the procedure. It was really quite limited. So we have to weigh the risks of the procedure to the patient as well as support staff. And specifically, how would the results change management? So if I was able to do the BAL and there was no infection, would you guys decrease or de-escalate antibiotics? Likewise, if it was a more of a lymphocytic infiltrate, would you continue the immunotherapy? Probably not. So this is where I think a pre-procedure multidisciplinary discussion is really essential, and talking about how a procedure will change, how the results of a procedure will change management. I'd love to hear what Dr. Adele has to say.
Eric, Adele?
That was pretty thorough. I'm not sure I can add a lot of detail to the conundrum that this has been giving all of us in our team. We actually have developed that multidisciplinary team. So we share, as a positive of COVID, we've developed a daily 30-minute lung cancer multidisciplinary tumor board. And it's intended for rapid case presentations to assist access to treatment, but also quickly turning around. And some of these cases, I would say we see 1 or 2 a week at least of this situation. I would put in, Dr. Fiedler, maybe the concept, the idea that aspiration should also be considered in this patient because of that patulous esophagus, but that I'm just a little bit biased toward it. But I do like the question that David asked regarding, first thing is, what are we going to do as far as treatment if we rule out? Because we can't rule this in that I'm aware of right now with any diagnostic testing. So I would guess that most of us would rule out an infectious process and then empirically hold the immunotherapy and plus or minus steroids. Is that the consensus? Or are we going to find that out as we go through the slide deck, maybe?
So that's right, Dr. Fiedler. Tell us, how do we diagnose this and how do we manage it?
Okay, so I can tell you, go back to the differential diagnosis slide, and I agree with Dr. Feller-Kopman. I did not think that this was radiation pneumonitis. I think it went too far outside of the radiation portals. It was within the realm of radiation pneumonitis, that 4 to 12 weeks after completing radiation, so it did fit in terms of time course. Despite her CT scan looking pretty terrible, she had relatively low volume of symptoms. Her biggest problem was her pain that was unrelated with the sciatica. So we did not cover her with antibiotics. We had done a point of care COVID PCR, but excuse me, especially with her respiratory symptoms not being 100% typical of pneumonitis, we did request a bronchoscopy. And so she had a PCR testing from bronchoscopy, which was negative for the viral panel, including COVID-19. And she was started on milligram per kilogram of steroids for pneumonitis. I hadn't seen too many cases. She was symptomatic in the sense that she had a fever, which started the whole ball rolling. But for her CT scans, she had oxygenation decreased a bit after her bronchoscopy, but that was thought more to be from anesthesia related. Immune checkpoint inhibitor pneumonitis can be focal or diffuse infiltration of the lung parenchyma, typically diagnosed by looking at CT scans. There are no pathognomonic, clinical, radiographic, or pathologic features. And the incidence especially on the PD-L1 inhibitors, is up to 5%. The high-grade incidence is not too bad. It's less than 2. It's generally 0.8 to 2%. And if you add the CTLA-4 antibody or use CTLA-4-based monoclonal antibodies, the incidence of pneumonitis is a little bit lower than what we see with the PD-L1, PD-1 immune checkpoint inhibitors. And the onset could be pretty much anywhere, but the average onset is about 2.5 to 21 months. And I found this nice chart that has checkboxes with the immune checkpoint inhibitors on the left and COVID-19 symptoms on the right. So we can certainly see fever, dyspnea, cough in both. Diarrhea, you can't see with the immune checkpoint inhibitors. That would typically not be from the pneumonitis, but from another immune-related effect of the immune checkpoint inhibitors, but not as much GI symptoms otherwise as have been reported with COVID-19.
And my understanding also is that the incidence of pneumonitis, although in the large initial studies was only up to 5%, a lot of the post-market data suggests that it could be even higher in the 15 to 20%.
It's typically with the low grades. It could be a little higher. And, I don't know in the post-marketing data, for example, I see patients, and we'll talk about it a little bit with some of the flows, that have zero symptoms. They come in for a routine restaging CT scan, and their CAT scan shows a few little patchy, tiny infiltrates. Is that really a grade 1? Probably not, so I think and even though it makes me a little nervous, I usually continue the immune checkpoint inhibitor if it's very, very slight. But if you call it a grade 1, then you're probably better off holding. The other unknown, I would still say, although we do have long-term follow-up with the Pacific trial, which was a phase 3 trial randomizing patients who received chemotherapy and radiation to immune checkpoint inhibitor or placebo. And I think everyone was nervous that the pneumonitis would be much higher, especially if there was an overlap with the radiation fields. And it really wasn't too bad. Interestingly, I feel like clinically, I see more side effects with durvalumab after chemoradiation, but not necessarily in the lung. A lot of dramatic hypothyroid, fatigue, joint problems. The pneumonitis incidence was really only especially of the grade 3, was only 1% or 2 higher in the treatment arm compared with placebo. So that was encouraging. Any other comments, Dr. Margo?
No.
Nope.
No.
Okay. So this is a busy table, and this Dr. Feller-Kopman was a co-author on this paper, and it took the ASCO. It's similar to the ASCO guidelines that came out in 2018 for immune-related events guidelines, and really modified it and honed it in the post-COVID era. So we can see some similar features to those original guidelines. Where grade 1, as we were just talking about, clinically is asymptomatic with radiographic changes. I don't know if the patient I presented would be considered a grade 1 because she did have a fever, although I think in general they think more of respiratory symptoms. But for grade 1, the recommendation is to hold the immunotherapy, and it's really a case-by-case testing for COVID-19, although I think most of us would probably run the test. And then to follow up, and if the symptoms get worse, treat as a grade 2. If the symptoms resolve in a month, most of us, especially if there's meaningful radiographic changes, would repeat a CT scan before resuming the immunotherapy. But typically not a reason to discontinue immune checkpoint inhibitors in our patients. For grade 2, we have clinically symptomatic, restricting instrumental activities of living. And we should screen these patients for COVID-19 and consider consultation and certainly hold the immunotherapy. But usually we would start prednisone or steroids at this point, typically 1 milligram per kilogram. I don't always do empiric antibiotics for the grade 2. Usually I do not. And the important thing is to follow these patients as they can get worse. And if there's no improvement, then the recommendation is to increase the treatment to a grade 3 level. For those patients who are COVID-19 positive, there is a recommendation to consider discontinuing the corticosteroids. And I'd love our pulmonologist on the panel to comment on steroid use with what you call grade 2 pulmonary symptoms, whether they're from COVID or the pneumonitis.
I mean, it's interesting. It's interesting that this paper mentioned that because maybe this was before the data became available on dexamethasone for.
Yeah, that's exactly right, Tim.
Steroid-induced pneumonitis, COVID-induced pneumonitis, which now we treat for 10 days, so dexamethasone 6 milligrams. And in fact, there was just yesterday, our section shared an email with a new paper showing that methylprednisolone may be actually just as good for COVID as well. It's not a very powerful study, but there is that suggestion in the literature, so maybe they get treated the same. I do have one question before we're going to move on to the next topic, Dr. Fiedler. There was one question from participants, and I want to make sure we address their needs. Do you think that COVID infection accelerates tumor progression? It's somewhat tangential to the pneumonitis story, but it is an oncology question.
Yeah, it's hard to know. I don't know if that data was captured well in the Teravolt. Just, we participated in just, answering the questions. I don't know if we'd get the data from the Teravolt study in that. Anecdotally, I would say it's really hard to know because when you get the COVID diagnosis, the therapy is typically put on hold. especially cytotoxic chemotherapy, when you know that that would portend to a worse outcome for COVID for lung cancer patients. Radiation therapy is often continued, especially if it's definitive and they're just treated at the end of the day. But chemotherapy is usually put on hold. I would put the immunotherapy on hold just because we have some reassuring data, but it doesn't make sense to add that into the mix at the time of an active COVID infection. And, we had restrictions on patients coming back into clinic, to receive, their next treatments for a while. And then when the volume of new infections dropped a little bit, we were able to get people back a little sooner, and then they were still treated in isolation. But I can't say that I saw someone who got a COVID infection and then all of a sudden their lung cancer was worse when I wouldn't have expected it to, but I think that would be a hard question to answer. The last point about the management of these patients, I'd like to get input from the other panelists is if there's a grade 3 for toxicity and it's not improving on steroids after 48 to 72 hours, the recommendation is to escalate. Usually with TNF inhibitors, you can use IVIG, some other immunosuppressants, and especially with the TNF alpha inhibitors, it's recommended to have ruled out tuberculosis. So our hospital is sending quantiferin, which takes a few days. So it's just something that I've kept in mind. And if I have a patient with respiratory complaints on immunotherapy, I'm asking the hospital to send it off right away in case they get worse. There may be some rapid other TB tests you guys are using. So just a quick comment, and then that'll be the end of my part. Dr. Adel, do you have any comment on that?
Well, I don't have a lot of experience, and I don't know the literature on escalation after steroids. By that time, they're generally in the ICU and they're pretty sick. It would be quantiferon's pretty rapid turnaround for the TB question once it's escalated. And I think that's, you can get that within 24, 48 hours at the most, I think.
Ours is a little slower.
Yeah, but I think that when you get past that stage, I don't know. I'd be interested in David and Tim's response regarding the acceleration and what evidence we have that once they are not reacting to steroids in this situation, I would be worried we have the right diagnosis.
Mm-hmm. I was going to say, I'm going to function as a panelist for a second here. I have only seen people on steroids. I don't think I've seen alternative immunosuppressive drugs for IO pneumonitis. Maybe my colleagues from oncology have tried that, but not patients I encountered in my clinic or in the ICU. It is 3:27. I want to make sure we have time for other topics. Go ahead, Eric.
Well, this is quick because I think the panel, the audience may be asking this, if maybe or maybe not, maybe it's just me. But in these patients, I try to get a COVID on all the BALs. Is that a practice that we would encourage? Even though they're PCR negative, we add COVID to the BAL. Are others doing that?
One big issue that came up, especially early to mid-pandemic, is that if you added the COVID testing to a BAL, it automatically triggered the patient into a PUI, a person under investigation, which means that if they were coming from a non-isolation room, they had to recover in isolation and then they couldn't go back to their standard floor room. So that was a big to-do. Because yes, I was very skeptical of how sensitive the nasal PCR was. And we all know that the BAL has a higher sensitivity. So we were sending those on a lot of people, but then infection control freaked out a little bit.
Interesting.
Floor nurses, yeah.
Initially, we had a hard time getting it because it was not standardized. So we had some pushback. But now it is done, especially if it's high in the differential diagnosis. We have anecdotal evidence maybe every few weeks when we do a lavage for other reasons. And to our surprise, we diagnose COVID by BAL, even though there were prior nasopharyngeal swabs that were negative. All right, let's move to the next topic. This discussion will be led by Dr. Feller-Cubman on the management of malignant pleural effusions during COVID times and beyond. And there were a few questions from the audience, but Dr. Feller-Cubman, how about you give us a highlight on how you approach this topic today and maybe a summary of the guidelines, and then we'll address a few questions.
Sure. So similar to our patients with presumed lung cancer, in which we really tried to make those a priority, I think patients with pleural disease had even a higher priority because they were acutely symptomatic. They couldn't breathe. And I think one of the biggest impacts on our malignant pleural effusion service is really trying to get the patient in and then out of the hospital. Patients were very reluctant to come in, and we actually saw them, I think, at later stages of dyspnea than they would have presented beforehand. Part of that could have been that they weren't used to doing their normal activities. They weren't going to the grocery store and doing the shopping. They were getting it delivered. So they had tended to come in with less reserve. The other huge impact was that it was really our standard practice to do IPC education after initial placement with whoever's going to be helping care for the catheter. And by hospital policy, those support people were basically not allowed to come in. It wasn't really until mid-pandemic that support people were allowed into the hospital. And I think because of that, despite us really trying to select patients who we thought could care for the catheter and would have the home support, and we were, had the luxury of having our own interventional pulmonary nurses who would do the education before the procedure over the phone and with video conferencing. It's hard. I'm not a big fan of the see one, do one, teach one methodology of teaching medical procedures, but I do think that seeing it and doing it for a non-medical person really helps the learning curve. And we actually saw a bump in our IPC infection rate, I think directly attributable to the secondary effects of the COVID pandemic, not COVID itself, but the effect of not having the significant other come learn how to care for these catheters. So in terms of the options for managing malignant pleural effusion, Tim has nicely listed 6 of these here. And I don't think the decision tree has changed with COVID. We still really try to place emphasis on patient-centered outcomes. So we continue to have the discussion with the patient and the family about the pros and cons of each of these interventions. Repeat thoracentesis is a fine procedure, especially for those nearing the end of their life, but we know that there's almost 100% recurrence of pleural effusion and malignant pleural effusion within a month. So we don't use that as an option for patients who have an expected survival longer than that. We try to do a definitive pleural intervention, and that could be either placement of an IPC alone. Number 2, it could be pleurodesis alone, and that could either be number 5 or 6, either with thoracoscopy and talc insufflation or talc slurry versus a chest tube. And then, of course, combination approaches where you're using IPC with talc. And the pros and cons of each of these haven't changed. We've nicely reviewed these previously. The benefits of both approaches is that they work. Dyspnea improves in over 95% of patients treated with either. IPCs tend to have a slightly higher complication rate in terms of infection. Thoracoscopy and pleurodesis alone, or just talc pleurodesis alone, has a higher incidence of additional pleural procedures. If you're doing thoracoscopy and talc insufflation, as long as patients are doing well, we will now do that as an outpatient. So a lot of these procedures can actually be shifted to the outpatient arena. Part of that is your support staff, your ability to communicate with the patients afterwards. So I don't think COVID has impacted that decision tree all that much as it has impacted the support care that patients can receive in the hospital.
Thank you, Dr. David, for your comment. Dr. Adele, Dr. Fiedler, any comments on your institution's approaches to malignant effusion before I go through some questions from the audience?
we have not seen that much of a difference in approach. And part of it has to do with we were allowing, and David brought up, and that's a good comment about not having an individual come in. We were allowing in the outpatient setting one member. We did restrict to nobody in the hospital. But in the outpatient setting, we felt we could control at the entrance and the exits and do a decent job. The volume was down a lot because the rest of the services we closed down for fear that we were going to overwhelm the hospital. But I don't think they compromised. I would ask, and Mary Jo and David, if we haven't seen maybe some improvement in remote education preliminarily. What we started doing was sending stuff out to initially get people to understand the procedure, that particularly the IPC is what I'm thinking of. And it was amazing how the nurses commented that they were better prepared coming in for their one-on-one. I can't say that's translated to anything other than maybe a little less anxiety, but some of the forceful communication that we've done with tele might actually translate into more efficient and more effective ways as we go.
Mhm.
Yeah, that's absolutely right. But I think it's important also to realize that you and I are perhaps practicing in the ivory tower where we have that support. And I think that's actually a great point for any IPC program, is that you really need that infrastructure to make it successful. You need the nursing support, not only for patient education, but to ensure that there's insurance pre-approval for the bottles and all that. So I think for those programs that have that, I agree that tele component has significantly helped.
Dr. David Feller-Cobman, there was a question from a participant that was submitted prior to the webinar in regards to the best chemical agents for pleural disease in case of malignant effusion. And I would add to that for a while, talc was not available on the market and people were talking about iodine and doxy. And can you summarize the literature in a sentence or two?
Sure. So I think all major societies recommend talc as the pleurodesis agent of choice. So that is true from our combined American Thoracic Society, Surgical Thoracic Society, and Society of Thoracic Radiology, clinical practice guideline through the ATS. It's true through Dr. Bibby was the lead author on the BTS guidelines that were published in ERJ. And it's true through the Cochrane Review, especially now that graded talc is available in the US. We're seeing almost no incidence of systemic inflammatory response or ARDS. The other agents, such as doxy, don't work as well. Iodine is intriguing. I've had colleagues around the world use it and swear by it. The mechanism there is thought to be due to its extremely low pH. It can cause significant pain, which tends to happen, I think, less with talc. But right now, talc is the modality of choice.
And since we're on the topic of thoracoscopy and chemical agents, there was another question in regards to diagnosis of malignant pleural effusion. The question reads, do you still find a pleural biopsy necessary in a patient who has a diagnosis of cancer with the concurrent pleural effusion? I know it's a little vague, but when would you consider a pleural biopsy in your practice?
So our practice is to first sample the pleural fluid with a thoracentesis, and we do a large volume thoracentesis to make sure that it is relieving dyspnea, because if the dyspnea does not improve, we have to search for other things that cause the patient to be short of breath, such as pulmonary embolism, tumor embolism, deconditioning, things like that. And also, especially now with improved cytologic markers, I think the yield from thoracentesis is actually better than historical data. That being said, it's only probably positive in the 70% range on the initial tap. If we're still concerned that this patient could have a malignant pleural effusion, and it will change management, either by guiding us into the treatment options that we've discussed or change oncologic therapy, then we would do a thoracoscopy. And again, we would do thoracoscopy as an outpatient procedure. We use small instruments, so a 7mm, 8mm incision, a 6mm trocar, and you could get biopsies with a diagnostic yield approaching 95%. Now, that is slightly different in patients with presumed mesothelioma. Those need bigger biopsies and more tissue. They need transition of involved tissue to normal tissue on the pleura, and they also would like tissue that goes down to the endothoracic fascia. So depending on those patients, I am a lot more aggressive on my biopsies and also have a lower threshold to get my thoracic surgeons involved.
Mm-hmm. Dr. Feller-Comment, there is a question that I suspect it's directly addressed to you. Do you routinely check intrapleural pressure prior to IPC placement? I don't know if you're seeing that or not, but I actually had a similar question, like in regards to the trapped lung and your decision-making process. But let's answer the participant's question. So, do you routinely check intrapleural pressure prior to IPC placement?
That's a great question. I would perhaps rephrase it a little bit. And the question is, do I check intrapleural pressure prior to attempting talc pleurodesis? Because in order to pleurodese someone, I need the visceral and parietal pleura to oppose each other. And there are several ways that you could identify non-expandable lung. You could do it with ultrasound. You could do it with post-large volume thoracentesis chest X-ray. You could do it at the time of thoracoscopy, either if done under positive pressure, if somebody's intubated, you could ask the anesthesiologist to inflate the lung, or you could apply suction with the semi-rigid scope and see if you could get the lung up. If somebody's getting an IPC, I actually don't care if the lung comes up or not. I care if the patient feels better. If they feel better with the thoracentesis and the lung doesn't come up, great. I could palliate their dyspnea with the IPC. If the lung does come up, great. I could still palliate their dyspnea with the IPC. They may have a higher chance of quote unquote autopleurodesis. However, in the AMPLE-2 trial, about 50% of patients with initial non-expandable lung still had lung expansion and pleurodesis at 6 months.
Which is interesting.
I hope that answers the question.
Yeah, I think so. We'll see what the participant thinks, but absolutely. That was actually one of my questions. Have you seen patients with trapped lung that eventually the catheter comes out? And I think you just answered that. All right, realizing we have about 10 to 15 more minutes.
I just would add one thing quickly about the biopsy. If a patient is a known lung cancer diagnosis and we have markers, we don't routinely push for it. But if it's a new diagnosis suspecting lung cancer, then I would prefer a tissue biopsy as well, because there's some centers who are really great at running in-house molecular panels on itty bitty, pieces of DNA. But usually for the common labs, we need, at least to send off 15 slides.
Yeah. So thank you for pointing it out. In fact, we were very fortunate here. We're on the 2 slides, even from EBUS TBNA, our lab runs like 1,241 genes. As you probably know, Dr. Fiedler, with Dr. Jodi Patel, when she was here, we published a few papers on that. Okay, moving on to airway obstruction for the rest of the session. We know that there is data on safety of bronchoscopy in patients with COVID. Thankfully, based on 4 papers that we had the opportunity to review, it seems that with the proper PPE, this intervention is safe and for the operators. We also know that it adds some value in terms of diagnosing superimposed infection. Depending on who you read, anywhere between 4 and 60% of people suffering from COVID, if they get a lavage, you may diagnose an additional infection. But what about therapeutic bronchoscopy? Is that safe during COVID, and what is the modality of choice? And that's where I will have Dr. Eric Adel chime in and comment on his approach to malignant obstruction during the times of COVID. Do you, Eric, prefer a certain modality? Do you feel that one is safer for the operators or for the patient during these times? How has COVID impacted your decision-making in regards to ablative modality stenting for malignant obstruction?
So thank you, Tim, and thank you again for the opportunity to participate in the panel. I've learned quite a bit through the first two participants. It's a very interesting dilemma that we have when patients come with malignant airway obstruction. I think if you go back to that the slide just before this one, Tim, I think that illustrates a very nice ranking of the various procedures and how we should be looking at that kind of assessment and what we do to patients, even without being in a COVID environment. One of the things that I think we've learned through the COVID pandemic is that not every time that we've done a bronchoscopy in the past, we actually need to do it. And we looked at it a little bit differently. Now, when a patient comes with symptoms, we started looking, I think, a little bit harder at were these due to true airway obstruction, so in the malignant category. I mean, intrabronchial obstruction. So initially, we started, and all patients, as I think Dr. Feller-Kopman pointed out, we put all patients under general anesthesia with a rat. We didn't know how safe it was going to be, so patients went under general anesthesia a lot more than they had. And these were even those that we would have generally done with maybe moderate sedation or deep sedation and kept them spontaneously breathing for treating their major airway obstruction. So it did sort of put on our minds a little bit different approach. But parenthetically, we continue to manage malignant airway obstruction like we have in the past. So when we manage these patients, the first thing to try and sort out is the type of luminal obstruction that they have. And the issue of predominantly intraluminal versus predominantly extraluminal will determine the primary modality that one would use. When you get into a mixed, you have many more options for that you can do. So if we had predominantly an intraluminal tumor, most people would still consider options available for endoluminal removal with either flexible or rigid instruments. I think that initially during the pandemic, people moved a little bit more toward flexible instruments because they had a better sealed system. That's anecdotal. But I was talking to a lot of my colleagues. They were doing more cryo resection, more flexible snaring, maybe than a rigid with mechanical debridement. But I think that we learned that that's not necessary, that if you in a good, reasonably well-protected environment, the system being that closed isn't critical. So I would encourage us to utilize those instruments that provide the most effective, efficient, and safe way. For example, if you're going to go and you have a major obstruction of, we'll make it easier, right main stem obstruction, and you can use a rigid bronchoscope, devascularize, and mechanically debride that, you can usually accomplish that within probably less than an hour. If you start to then use instruments such as cryo debulking, maybe APC, you might extend that procedure by another twofold. It's just not as efficient. And I think that those are the kinds of things that we, as we reflect back to what we might have changed in the COVID environment, but as we go forward, that we need to keep in mind that the tools should be effective and efficient in managing the patients with malignant airway obstruction, particularly because of the underlying comorbidities. These patients are sick. The longer they're under general anesthesia or on the table with us taking care of them, the more potential complications they have. So endoluminal, still with rigid mechanical debridement if possible. The utilization of other therapies are still optional. You have the photodynamic therapy that people would use for certain tumors. And when it comes to a extraluminal, In the malignant category, I'm not any longer concerned about anything other than, again, expediency. If you can place a self-expanding metal stent and palliate this person quickly with a flexible instrument, I think that's an effective way of managing them. If a silicone stent, or if it needs a carinal Y stent, then a rigid with a silicone stent may be the most effective. And then the mixed lesion, you're going to use the combination of all of the above, depending upon things like a patient who's on anticoagulation. If they're going to be on and off anticoagulation, you may err on the side of placing some sort of airway prosthesis so that you help with that recurrence of maybe not having to take them off their anticoagulation again should they grow into the lumen. Those are judgment calls that are hard to do, but there is a reason for a mixed lesion or even an interluminal lesion where they've maxed their therapy. They may be a candidate for some sort of airway prosthesis if they're on anticoagulation. Mm-hmm. In those patients with COVID, I don't think that there's a change whether if they have COVID with a malignancy of what tools you might use.
Thank you, Dr. Adel. There is a question from, I want to make sure that we're addressing the learners' needs. There is a question from one participant in regards to the pros and cons of electrosurgery like APC versus cryotherapy versus PDT. Can you walk us through your decision-making process really quick? If you want to use an ablative modality, which one do you usually choose in your practice, and maybe rationalize that in a sentence or two?
It's probably my age. I think you get the best control of bleeding with the devices such as a YAG laser or KTP laser. You get better depth of penetration. It's more efficient, and mechanical debridement is much easier. APC, the depth of penetration with the new instruments is a little bit more, but it's not nearly as effective as the laser therapies. From the standpoint of photodynamic therapy, you can get debulking effectively, but it's delayed. Patients have photosensitivity. So in the order that I just said, cryotherapy, cryodebulking, I use it in those areas where I'm having trouble with mechanical debridement potentially. But remember, there's a potential and there's some suggestion of increased bleeding with cryodebulking because you don't get good coagulation. You get temporary bleeding control. So laser, probably heat with APC, cryo, PDT in that order.
Thank you for that. And there is I actually do have this question for the three of you, but especially for the interventional pulmonologists in this panel. Given the fact that we'd like to restore airway patency in a more definitive way, maybe avoid repeated interventions during a time of a pandemic, have you noticed an increase in the number of airway stents in your practice in the last 15 months or not? I guess it's a yes or no question.
I don't know.
Yeah, I don't think so either. Actually, as I've gotten more gray as well, my use of stents has gone down in general. And I don't think I've seen it increase over the pandemic.
It's a great question. You'd be tempted to just put in a stent and move on because of the issue. But
stents have their own associated complications.
That's right. Yep.
Yeah.
Big time.
And that's the voice of wisdom. We have 2 more minutes, actually. I'd like to have each of you think about a take-home message in regards to what you learned in your practice in regards to managing complications from cancer in the last 15 months that you'd like to share with our audience. Dr. Fiedler, how about we start with you?
I would say that some aspects of patient care has actually improved with the COVID pandemic, and that's with telemedicine. Patients who wouldn't necessarily come to the clinic, for weekly checkups because it's too far, it's too much of a hassle, will have, telephone visits or video visits, and I think that that's helped. I also think that our having COVID in the back of our minds is always there with, patients coming in with new respiratory symptoms. But we've, been able to, with excellent nursing staff, manage a flow with procedures in place that have really kept everyone in the cancer center and the patient, including the patients, most importantly, safe too. So that has been our motto, that the cancer center is a safe place, and please come for the treatment, that you need.
Thank you. Dr. Feller-Cubman.
Yeah, I think the two biggest things that I've learned is number one, thank God PPE works. We're all very scared of getting COVID and putting ourselves and our families at risk initially. And with good PPE, we're able to do our jobs safely. And the other thing is keep an eye on the literature, because it's a changing field. As we pointed out with that NADU article, talking about not giving steroids, and then we learned that steroids are actually helpful. So don't take what is printed as gospel. It's a moving target.
Thank you for that wisdom. And Dr. Eric Adele.
I'm going to second each of the panelists' comments. The telemedicine is here to stay. The PPE is here to stay. We have, I think, the learning of not getting simple viral infections in the aerosol producing procedural world that we live in. We should be wearing our PPE from now into the future. It becomes cumbersome sometime, but I'd like to see the reduction in viral infections that we've seen, other than COVID this winter, continue as we work in the hospital. And I'd also like to continue to connect the robust connection that we've made with patients when they're in their own environment that we see with telemedicine. So a virtual environment, I think, is good for patient care as we go into the future.
I want to thank all of you for taking time away from your practice to share your expertise and your institutional practices. I trust the learners, the participants appreciate that wisdom. And for all of you participants, I am looking forward to seeing you virtually or in person at our national meeting down in Orlando. Stay well and be safe, and thank you for joining us today. Good afternoon, everyone.